So our final speaker of this panel is Dr. Wendy Chen, and she's going to talk about views from the clinic.
Hi, so thanks for organizing such a great conference. I hate to disappoint people, but I do not have any astronaut pictures. Those were really cool. So what I'd like to do is I'm a breast cancer medical oncologist, and I've only recently started being interested in body composition, mainly due to collaboration with Betty, so I have to thank Betty for that. But before that, I did a lot of cancer epidemiology, and I used to always ask myself, I work with the Nurses Health Study, is when we do find something in the Nurses Health Study, when is it ready to move to the clinic? What do you need to do next to really change how people are going to do things? And that's what I wanted to talk about today in terms of not so much how do we change what the current research is going on in terms of body composition, but how do we get clinicians to care and engage about body composition and treat how we change patients. And I really think, as has been highlighted today by the workshop, is that this is really an ideal time to influence clinical opinion on body composition. I'm obviously not going to summarize all of the great data here that have shown the importance of body composition, but I think to think about right now it's important because, again, clinicians have finally agreed that body weight and physical activity in cancer survival, that is important. I can tell you until recently, people didn't believe that. People didn't believe that those things were important for cancer survival, but finally ASCO has, changed guidelines and issued position statements regarding the importance of body weight and physical activity. There's a lot of interest in mechanisms of body weight and cancer risk and survival, and I'm sure everyone has seen all these manuscripts and articles about the obesity paradox and other sorts of things. So there's a tremendous amount of interest among both clinicians and journals. And then, as everyone knows, they also have to recognize this increasing clinical importance. They do have this ICD-10 billing code for sarcopenia, and there are also billing codes for dietary and weight loss counseling. However, these are not that widely used yet for a variety of reasons, partly due to exactly how reimbursement works. So right now it's actually probably not the best way for people who are interested in using electronic medical records to try to identify people. It probably is not the best way to try to identify folks because clinicians are still not using at least the sarcopenia billing code very much. It's actually very underutilized right now. But what I would argue is that body composition and the way that we should try to move this field forward clinically is to really try to get clinicians to think of it as a vital sign for cancer patients. And as I said, we already now routinely, whenever you go see your doctor, you always have your weight calculated. And right now the computer actually automatically calculates body mass index for every patient who comes into the clinic, not just at the Dana-Farber, but at any clinic right now. It's part of the vital signs. It shows up in my note when my vital signs go in. But body composition, as everyone knows from this conference, really is as important, if not more important, than weight and BMI, which is already routinely recorded. So in order to get clinicians to engage, you have to answer these two questions for the clinician: is why should they care about it, and also how do we do it? How do we do it in our busy clinic when we have so many other things that we're trying to do? And so I think the first question is why should clinicians care? And I'm going to cover a couple of things in trying to get our message across is that it's important across the entire population. It's associated with key clinical outcomes, and it can guide clinical interventions. And so there are several, I think, important misconceptions that clinicians continue to have about body composition. And part of that is driven by the fact that the older literature really focused more on metastatic disease in the geriatric population. So even the word sarcopenia, even though it has a scientific definition in terms of being low skeletal muscle, people sort of think of it in a negative way, and that it became the specialized problem, that sarcopenia was a problem that was, again, mainly in metastatic patients or among geriatric patients and really did not apply to the larger group of cancer survivors. And I think there's also, when I talked with my fellow clinicians, there's a lack of knowledge regarding body composition measures. They sort of think, well, it's just a fancier way to do BMI, that's all that it is, and that it basically does maybe measures a little bit more precisely, but that it doesn't really capture anything that different than a BMI. And importantly, they really sort of focus on fat and don't think about the importance of muscle. And so again, it's a big misconception, especially now when so many of the clinical guidelines focus on weight. They just think of adiposity and don't think of both adiposity and muscle. And so just to show some of the data that I have been working on with Betty, this is looking at the data set that combines patients from both Kaiser and Dana-Farber. This is using clinically acquired scans, and this is also only stage 2 and 3 breast cancer, because in contrast to colorectal cancer, we do not routinely do CAT scans in patients who have stage 1 breast cancer, but when it's lymph node positive, stage 2 and 3, we do CAT scans at the time of diagnosis to rule out distant disease. So this is all at diagnosis. This is before anyone has gotten any chemotherapy, radiation. It may be before or after surgery. And as you can see, across a wide range of age groups, there really is a fairly high prevalence of sarcopenia. That's the black line. Non-sarcopenia is the blue line. The cutoff that we used here was 40. And so this really highlights this idea that sarcopenia is not something that we just think of in the geriatric population. It's also not something that we only think of in the metastatic population, but these are newly diagnosed people sitting in this room right now, and it's incredibly prevalent across all age groups. And also to show that it captures something very different than BMI, as Carla had just shown, the prevalence of sarcopenia really varies across all BMI categories. So it's not something that's only in the underweight, even though, yes, the percentage is higher, but even among the obese population and also among the so-called normal weight, so people with a BMI of 18.5 to 25, as you can see, there really can be quite a high incidence of sarcopenia. And all of these things change with age. This is not longitudinal data. This is, again, cross-sectional data, and it shows you that, again, there are these different measures that we need to be looking at in terms of the skeletal muscle index, the muscle quality, in terms of the fat, and how all of these change over time. And again, these are issues that are not just limited to the elderly or people with metastatic disease, but really occur across all ages. And this is, again, something that's very important to get across to clinicians. And also that, again, across BMI, that, again, adiposity can also be an issue among thinner or so-called normal weight people. A lot of those people, again, you think, well, someone's weight, the BMI is between 20 and 25, therefore we don't need to worry about that person in terms of any exercise and nutrition interventions, as Carla and Jessica already highlighted, that's not true. You really need to personalize things, and we should not be using body mass index to personalize things, which is how clinicians currently are thinking about things. That's their idea of personalizing things, would be personalizing things according to what their body mass index is, or personalizing things according to what their current level of physical activity is, because that's actually how they think of things. And so what we have to do is try to get people to reframe how to think about people and how to risk stratify people. So then how you do that? And one of the primary things I would argue is that you do have to publish in clinical journals. The clinicians are not going to read a lot of the journals that a lot of the wonderful work that's been presented today have been shown, and if you can't reach the clinician, they're not going to change their practice. And so in order to do that, you really have to emphasize the clinical significance of findings, define the study population, and focus on the translational clinical impact. And the clinical significance of findings I really can't highlight enough, and that really is thinking about the difference between clinical versus statistical significance. And I think this is a problem a pitfall that honestly oncologists fall into this all the time. We spend all this time doing a clinical trial, for instance, that shows a 1-month difference in overall survival that happens to be statistically significant, and all the clinicians get very excited because, oh, gee, it's statistically significant, but honestly 1 month is not a clinically significant difference in terms of overall survival, and so it really is the magnitude of the difference versus the p-value. And the similar thing is in the weight loss in terms of these intervention trials. I would argue that it's similar in the weight loss randomized trials in which you see people, they spent 5 years of doing a randomized weight loss trial, and then they show an average difference in weight gain or loss between the two groups of 2 kilograms, which turned out to be statistically significant because it was a large randomized trial. And I can tell you from the Nurses' Health Study, because we have a large cohort, we get statistically significant results all the time. I mean, it happens all, and that's because you put enough people in there, you can get a statistically significant result with very small differences. So I think, yes, it's important to have statistically significant results, but you really can't frame your research and things that, oh, these are things to get excited about just because you had a particular p-value. And so again, when you're looking in terms of the body composition area, you're looking at different measures of body composition, and you say, oh, gee, this one is statistically significantly better than the other one. Again, is that difference clinically significant or not? And I think the other thing, which I think sometimes people forget, is for the cancer population, you really need to define the study population. So as everyone has alluded to, cancer survivors are a heterogeneous group. And how I'm going to make that argument is they're a heterogeneous group clinically. So as a clinician, I think very differently about someone who's metastatic versus non-metastatic. So if I see a publication or a study in which they group together metastatic versus non-metastatic patients together, I honestly say to myself, I'm not sure how I can interpret this type of data, because you think about those things very differently. So someone who loses weight, someone who has adverse effects of body composition when they're in the metastatic setting, they've got so many things going on, versus someone like I showed before who's early stage, has not been treated yet, early at the time of diagnosis. I think of body composition very differently, and it's also what those mechanisms are. Someone who's got metastatic disease and has muscle wasting or low muscle mass is going to be very different than someone who's newly diagnosed, has not been treated yet, and that person also has a muscle wasting. The mechanisms are different, and the consequences are very different. So when people design trials, you can't lump together metastatic and non-metastatic patients. And also when you do studies, not just trials, but when you do observational studies, you have to separate them out. And you also have to think about the types of treatment. Without a doubt, chemotherapy affects body composition. We all know that. And so you do have to realize it's not so much what type of chemotherapy they got, because that probably doesn't affect that much what type of chemotherapy, but where is the timing of the chemotherapy and the surgery and the radiation in relation to the things that you're studying, and where you're designing interventions, again, where is someone? And then a clinician always asks, when they see some results, they always look at the study patient population and say, how similar is it to the people that I treat, in terms of deciding, is that going to change what I do or not? And if the patient population is really different than what I see, even if the results are very interesting, I may not feel comfortable sort of applying it to my own patients. And then most importantly is the translation of clinical impact. And I really can't highlight this enough, is what would I do differently for my patient? And so when you're looking to publish in a clinical journal or trying to get people excited, you have to be able to do that elevator pitch, in which they ask you, what would you do differently for my patient? And you should be able to answer that in one sentence. It's like, this is what I would do differently for my patient. It's not enough to say, oh, gee, your patient has a worse prognosis. Especially if we're taking care of metastatic patients, we already know that they have a bad prognosis. I honestly don't need someone else to tell me that. And the basic science literature is filled with things like that, in which they're able to see things that are associated with a worse prognosis or a better prognosis But if you can't answer that question, what would I do differently for my patient, we're really not going to be that interested. So like I said, the prognostic impact alone is going to be insufficient in terms of sort of changing clinical guidelines, because again, the basic science field in terms of tumor biology is littered with those things, prognostic factors that increase your risk. And I think you should consider partnering with clinicians for messaging and terminology, because especially for the clinical journals, there is a slightly, just there is for epidemiology journals or nutrition journals, we sort of have our own world of talking about things, and it's helpful. It's a sort of small thing, but it is helpful to make sure that the terminology and everything is appropriate for the place that you're targeting. And so what I'd like to do now is just talk about a few. This is not meant to be an exhaustive list, but one that's meant to be sort of thought-provoking to set up the talks for later today, the discussions that we have about opportunities to change clinical practice. I think one thing that's important to remember, and as I said before, although body composition predicts prognosis, it is never going to supersede the genetic and clinical tests that we have. That it's just not going to happen. In breast cancer, for instance, we have Oncotype DX. We have all these other type of gene expression assays that we are using more commonly, and so we're never going to replace those things. So other areas that I can see would be in terms of guidelines, intervention, chemotherapy dosing, and then risk stratification for surgery. So for example, the current guidelines for cancer survivors, as I said, really focus on weight management, obesity, and BMI. So the American Cancer Society guidelines, these are from 2012, this is what they have: maintain a healthy weight, exercise 150 minutes per week, including strength training. And this really led to a large randomized trial that is currently going on, enrolling subjects all across the United States, run by one of my colleagues at the Dana-Farber, Dr. Jennifer Ligabel, and it's 3136 breast cancer survivors. These people are all newly diagnosed. They're within 1 year of diagnosis. They have to be lymph node positive, so stage 2 and 3. They can be estrogen positive or estrogen negative. And I remember talking with Jennifer about the design of this study, and all they're interested in this study is weight loss. That is their only goal. They were not interested in strength training. There's a small sub-study in which they're looking at body composition a little bit, but that's what their whole idea is. We just want to lose weight. And if your BMI, and you also need to have a higher BMI. If your BMI was not high enough, then the answer is you can't do the trial. It's a BMI of 27. Is what they used. And so the idea is that, gee, if your BMI is under 27, we don't need to intervene on you at all. We only need to intervene on the people with a BMI of 27. So this is an area where, as Carla and Jessica were saying about personalizing guidelines, this is an area where there is definitely a clinical opportunity where you can influence clinicians and say, look, there are other things that you should be looking at. The guidelines should be written differently so that it better reflects what the underlying risk of the population is. And then another opportunity, which was only alluded to briefly, and I think the body composition data there's not been quite as many studies, is really prostate cancer. And this is a great area for people interested in body composition, because androgen deprivation is now quite widely used in prostate cancer. Before, it used to only be used in metastatic disease, but now it's actually used for locally advanced prostate cancer as well. And there are many observational studies that have shown an increased risk in cardiovascular disease that has not been shown in any randomized trials yet, probably because they're not powered well enough to do that, but multiple observational studies have shown an increased risk of cardiovascular disease and also increased risk of death due to cardiovascular disease. And the randomized trials, however, have shown there are clearly adverse effects on body composition associated with the use of androgen deprivation therapy, specifically a decrease in lean body mass and an increase in fat mass. However, the current guidelines just focus on treatment of individual factors. Basically, if your cholesterol gets high, give them a statin. If their blood pressure gets high, give them an antihypertensive, and that's what the current guidelines are focused on. Whereas if you try to fix what the underlying problem is, which is the changes in body composition related to the androgen deprivation therapy, then you actually don't have to worry about giving someone a statin and giving someone an antihypertensive. And this really, I think, is a field that we haven't, the body composition hasn't done as much as a prostate cancer, to really think that this is really just an excellent opportunity, and it would be a way that body composition really could be used as a biomarker. So then we could actually move the field of body composition, which not just for cancer, but as a biomarker for cardiovascular disease, or as a biomarker as both an exposure and also an endpoint, and so to think of it both ways. And chemotherapy dosing is something that we've thought about as well. So dosing is really crucial for chemotherapy efficacy. This is based on many studies in which you need to deliver both dose intensity and then also a certain total dose. And the way, and for people who aren't oncologists, they probably don't realize this, the way that we come up with, at least more recently, the optimal drug for a dose is basically you do these phase 1 trials in which you keep on giving the highest dose possible before they reach what's called DLT, which is the dose-limiting toxicity. And once you hit DLT, you actually stop, and then you give one dose below. So the actual dose that we give for chemotherapy was not based upon efficacy studies. It's actually based upon what's the highest possible dose someone can tolerate. And once you've found that dose, you then say, well, how you then do a phase 2 study, which says how effective is this cancer drug for people. But then no one then goes back to look and say, well, gee, if we give them a lower dose, is that lower dose equally effective or not? But those studies aren't going to be done because they need to be, they're too large, they'd be too expensive to run, and they're not done that way. But it's a hard thing to sort of overcome, this idea that we give everyone the highest tolerated dose. ASCO recently, a couple of years ago, have issued a clinical practice guideline in which they really recommended full weight-based dosing. Many people in the past had been for unclear, I shouldn't say for unclear reasons, because of misconceptions that people who are obese would have trouble with toxicity with chemotherapy. They were actually purposely underdosing people. And so now the clinical practice guidelines have really come out to say that you need to use weight-based dosing. But as everyone knows, that's using body surface area, which is very old. I think what's important to remember is in the adjuvant setting, to get people to lower the dose is hard because you're treating people with curative intent. You've already shown that this certain dose works for curative intent. So to say to someone, well, gee, they'll have less nausea or less toxicity, that's honestly not going to sell to clinicians. Clinicians are concerned about dose delays and reduction in the adjuvant setting, so that's something that would say, look, your patient's being dose delayed, they're therefore not getting the appropriate dose intensity, so then that is an argument that works. But to say that, gee, you have more side effects, the way that we'll answer is, well, we'll just try to work on getting those side effects better. And so again, this is a situation in which you're looking at the chemotherapy dosing studies. We really think about metastatic and adjuvant patients very differently. And that's because in the metastatic setting, we are not curing them. So what we're trying to do, obviously, is, yes, we want to prolong their life, but for most people, both patients and clinicians, you don't want to prolong someone's life at any cost. And so in the metastatic setting, we actually do care a lot about toxicity, and we are willing to, lower someone's dose a little bit, change things up a little bit in the metastatic setting, because there are two things that we're going for, not just effectiveness, but we're also going for quality of life. There are many situations in the metastatic setting in which I've treated someone with a drug that was effective and was working great, but I actually stopped it because their quality of life was terrible, and they said to me it just wasn't worth it. And so we really think about chemotherapy dosing differently. So for people who are interested in designing studies to affect chemotherapy dosing, to really keep in mind those differences about how we think about the adjuvant versus metastatic setting. And then the final clinical opportunity is regarding operative risk. And so risk stratification scales are already widely used for various procedures. CT scans are routinely done preoperatively. Surgeons really want to decrease postoperative morbidity and mortality. Surgeons often have open conferences in which everyone's statistics are put up in terms of their postoperative morbidity and mortality. They really want to decrease these numbers. And so this, again, is an area. But, again, you have to sort of pick your battles. And the idea would be to focus on these high-risk, poor prognosis cancers. So you focus on the cancers in which you're not automatically going to take someone to the OR. There are certain cancers which we treat with curative intent, breast, colorectal cancer. Those are lower risk surgeries. We basically will take almost anyone to the operating room for those things. One of my friends, her 90-year-old mother was just taken to the operating room for an early stage colorectal cancer, and she did great. But when you're talking about pancreatic, lung, hepatocellular carcinoma, the surgeons are much pickier. They don't want to just take anyone to the operating room. They want to be careful about who they take to the operating room. And there's an increasing literature regarding teaching surgeons, this is how you use body composition to decide who should I take to the operating room or not. And surgeons, again, are very open to hearing about these things because, you know, they want people to live after surgery. So the ideal body composition to think about what can you do for a clinical setting, it really is important to use clinically acquired data. I know that there have been a lot of measures that people have talked about today that they said that they're easy to do, they're not invasive, but it really has to be clinically acquired data. People don't like to have to come in to make an extra visit if they don't have to. It needs to be automated. If a radiologist or someone needs to do something extra, they honestly are not going to do it. We just don't have time and sort of bandwidth to do extra things. So, you know, people, and we haven't had any presentations about that during this workshop, is I know that there are other groups working on automated ways that from the CAT scan without human input that they can calculate body composition. So to really work on ways that are automated. And for example, breast density, that was something once the legislation came through, there's software, it could just easily go onto the mammogram reports. And then even though, yes, it's important to better understand the underlying biology, for the clinical setting, they really do need to be standard cutoffs for clarity. They can be gender and BMI specific, but for instance, to have one cutoff for lung cancer, another cutoff for pancreatic cancer, another cutoff for breast cancer, even though, yes, that may be more precise, in the clinical setting, again, if it's that complicated, then everything will really need to be rethought because you can't have a different cutoff for every single disease. And I would think for the clinical setting, it needs to be good enough and not perfect. And one example that I think of is estradiol. So estradiol, we have these sort of super sensitive estradiol tests that we use in the research setting to better risk stratify people. But in the clinic, I just want to know whether they're pre or postmenopausal. That's all I want to know. And so we actually don't use super sensitive estradiol assays. We just use the regular everyday estradiol assays within the clinic. And for our clinical purposes, those are really good enough. And so in conclusion, I really think that now is an ideal time to incorporate body composition into clinical practice. So we really should take this opportunity to think about that's the way to move the field forward, to really focus on clinical translation and also the important and ease of use and the clinical setting, and to really remember, I think there are just tremendous potential clinical opportunities to sort of move things forward. And thank you very much.